Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today's topic is removable partial denture. It's a series. It'll be of several lectures and then we'll move on to the complete denture series as well. So we'll begin with a little bit of introduction of the series and then the consequences of tooth loss. We'll move on to two types of dentures for RPD section. There will be tooth supported, such as this one here, which is teeth on both sides of the edentulous space. Moving on to tooth and tissue supported, and generally that has to do with distal extension spaces, whereas there's teeth only on one side. Then we'll take a look at how we make the partial dentures and the steps involved in it, and then of course the infamous partially edentulous arches classification known as the Kennedy's classification and Applegate's modification rules. There are 8 rules we will take a look at when making a partial denture. And then lastly will be references we use for our lectures and summary. So, introductions. The objectives of prosthodontics. What's the basic objective? We have to eliminate, so basically it's a rehabilitative science, right? We have to eliminate oral disease to the greatest extent possible, basically restore function, right? As well as preservation of health in relationship of the teeth and the paraoral structures. That includes the gums, the cheeks, the periodontal health, the tongue, and all of its relations. The restoration of oral functions, that's the final consequence of this entire rehabilitative process known as prosthodontics, making it more comfortable, aesthetic, pleasing, and it does not interfere with patients' speech. And of course, that's part of the function itself. So if you look at the diagrams on this area, it looks like a lot of the teeth have been restored. For example, in A, it's the fixed partial denture that restores missing teeth number 10 and posterior 5 and 13. Now again, these numbers are dependent on the universal system, so that's why the numbers are like that from the American textbook. But essentially, it's replacing a certain number of teeth. Wherever you notice, for example, this acrylic denture base replaces these teeth with the support of natural teeth here. There is some design structure here that we will dive into, such as rests and reciprocal arms and retentive arms and so on and forth. Here you'll notice a really big connector that connects one side to the other side, and that's called the major connector. And then there's something coming off of the major connector going onto the components of the retentive and the reciprocal components. That's called the minor connector as well. So all of that gibberish, let's take a look at how it works. First of all, consequences of tooth loss. Tooth loss has two types of consequences, right? There's anatomy and there's physiology. Anatomy is local. So basically a concept of residual ridge resorption. Residual ridge resorption is whenever there's a tooth sitting inside the alveolar bone, the alveolar process, the bone remains healthy. It has something to lie back onto. As soon as the tooth is lost, the bone will collapse. Now, because the bone will collapse, there will be a ridge reduction. And that's a whole concept, actually. It's very deep. Now, height and width of the ridge is lost. That's exactly what the residual ridge resorption will entail. And of course, the bone loss is greater in the mandible than it is in the maxilla. That's because in the maxilla, there's a lot of supporting structure that distribute the load, whereas the mandible is a free-floating bone just by the TMJ, therefore has more greater bone loss. And bone loss is greater in the posterior than the anterior, just as a rule of thumb. Mandible becomes broader, maxilla becomes narrower. Okay, what does that mean? Well, if you think about it, if this is your mandible, right, and kind of comes out and goes in, apologies for the drawing, let me redraw that for us here. So, if the mandible comes out like this. Okay, now imagine if there's bone loss. We said that posterior has a lot of bone loss. This is a negative sign to represent bone loss. It reduces the bone in this direction, right? In this direction. What that does is it makes it look like the mandible has grown out because it's become thinner from the lingual side. Therefore, it becomes wider, it becomes broader, whereas the maxilla in relation to the mandible becomes narrower because in the maxilla there is going to be bone loss from the buccal direction. So it would be essentially, if this is the maxilla, right, there's our rugae area, palate area, midriff, it loses its bone density from the outside, and that makes it narrower. Okay, so attached gingiva, keratinized gingiva, is now replaced by a little less keratinized gingiva because there's no stimulation, there's no tooth needing keratinized gingiva. But unfortunately, whenever the gingiva is not keratinized, it injures easily. So we're prone to a lot more soft tissue injuries as well. And then, of course, comes the physiologic consequences where the neuromuscular aspect. Now, neuromuscular is whenever the nerves are involved with muscular function. With oral sensory, feedback mechanism is reduced, which means if you have a bolus of food in the mouth, and whenever that food touches oral mucosa, there is a sensation that goes up the sensory pathway and comes down as motor response, and now we have chewing. But because we have no teeth, no PDL, and the PDL has now lost the neuromuscular sensory cells. Therefore, there is no feedback mechanism and there's no motor mechanism. Therefore, the chewing reduces, mastication reduces, and so on. This set of cells is known as the periodontal mechanoreceptors. They control effective masticatory functions with the central nervous system. In response to the periodontal mechanoreceptors, the CNS, central nervous system, produces a muscular guidance, that is the motor response to the sensory stimulus. Aesthetically speaking, a reduced facial height and a compressed lip support is seen, just like seen in this photo. This is the normal profile. Imagine the teeth being lost. All of that tissue is now sagging over a lost bone structure, and just like shown here, this is probably years after tooth loss. Wow, the pen is being terrible today. Sorry, guys. After bone loss many years later, the tissues that cannot now reduce, right, they just kind of sag over the remaining bone structure. Therefore, the social stigma kicks in, where there is association with missing visible anterior teeth is so significant that your smile is compromised, you start smiling less, and so on. Now, definition-wise, removable prosthodontics is more of an umbrella, and removable partial denture is an aspect of that umbrella. So removable prosthodontics is a branch of prosthodontics concerned with the replacement of teeth and contiguous tooth structure for edentulous or partially edentulous patients by artificially substituted teeth. Now, this is the glossary of prosthodontics number 8. Removable partial dentures are actually just prosthesis that replaces some teeth in the oral cavity in a partially dentate arch. It can be removed from the mouth, again that's important, and then replace that will called the RPD, some people call it the CPD, cast partial denture, some people call it the APD because it's the material that it's made with is acrylic, and they're both valid for different indications, of course. So let's take a look at those. Acrylic partial dentures, these are made up of acrylic resin. Okay, that's first. Then there's clasps that are made of wrought wire. Now, what's a clasp? Clasp is basically whenever there's a tooth structure that is being used to support a edentulous spot. This area is, of course, covered with the acrylic resin, and then a wrought wire. Wrought wire is supposed to be more flexible than cast wire, right? Remember, cast wires will be more used here. So wrought wire will come across the tooth structure that is being used as an abutment. Abutment is the support tooth, and it kind of wraps around the tooth. That's called a clasp. Now, of course, acrylic and then a metal wire coming out of it. These are kind of just imagine a plastic flipper, right? That just sits on the gingiva. our alveolar ridge kind of serves the purpose, either temporary, or there are indications for it to be long-term. So let's take a look. This is, of course, known as, there we go, flippers. The entirely tooth-supported region is supported by the acrylic denture base. Long-term use will lead to gingival recession. Therefore, temporary use is much better for acrylic. They're not very, say, bio-friendly with the gingival tissues, especially the acrylic here. Therefore, these are also now known as gingival strippers, and it's used only as a temporary denture. Many times it's used as a temporary denture right after you've got multiple extractions done, and then you put that acrylic denture while you're waiting for the extraction sites to heal. So we're going to call that immediate denture, right? Perfect. Now, cast partial dentures. These are much stronger, by the way, but more complex to make. Mainly fabricated by lost wax casting method, hence the name. Now, what does that mean? Well, just as this acrylic denture is made up here, imagine making that with a wax design, right? There is a step involved in this process for cast partial denture where wax is used, put into a mold where the wax is burnt out and then replaced using casting metal. Normally the casting metals could be, say, cobalt chromium or nickel chromium or nickel cobalt chromium, and those are the most commonly used metals. Now, these teeth that are made on the cast denture bases, they're made up of acrylic resin. Now, imagine this, acrylic teeth opposing natural teeth. What would happen? Natural teeth win that fight. So over time, the acrylic resin teeth might actually recede a little bit, attreat a little bit. But unfortunately, the other way is also possible. The enamel coming into constant contact of, say, certain occlusal interference, which I want to put out here. Occlusal interference is a whole topic that you need to consider whenever making RPDs or CDs, and of course we have a lecture on it as well. That will lead to the attrition of natural teeth as well, and that back and forth war ultimately leads to the failure of partial denture. Therefore, occlusal schemes, another lecture of ours, is very, very important when fabricating any type of denture. Okay, there are two types of cast partial dentures. There's a clasp retained, then there's an attachment retained. Now, the clasp retained is the most commonly made clasp metal retention denture, whereas the attachment retained is a little bit more fancier version, let's put it that way. It uses prefabricated attachments that are used for retention. We make a lot of cast metal clasps. Okay, so here's what it looks like. We see here the denture base is completely out of plastic. Plastic attaches with a dentulous ridge area, and of course the acrylic and the gums are bad friends. They are friends because they serve the purpose, but they're bad friends. Therefore, they're just known as flippers or gingival strippers. Okay, whereas the cast partial, yes, the acrylic does come into contact with the gingival structure, of course, but underneath this acrylic area, there's actually a metal grid work, and the metal grid work is overlain, interwoven with this acrylic component. So what that does is it kind of gives it this structure, like a scaffold. You know, have you ever seen a building being made? There's actually beams that are beams connected, and then cement is poured among the beams, and now we have a proper wall. Therefore, the wall doesn't fall, and this scaffolding kind of gives it structure. So that's cast partial dentures. And of course, these clasps are the other difference. These are made out of wrought wire or cast, depending on the indication used. So let's talk about certain other types of dentures that kind of fall under the umbrella of the other two. There's interim, transitional, and treatment. Interim dentures are basically, they enhance the aesthetics, the stabilization, and function, but for a limited time. Interim, within the terms, between two terms, interim. Inter means between two, among two. Now, prospectively, it is then replaced by a definitive dental prosthesis. That's almost the treatment denture, right? And then comes the transitional. It serves as an interim prosthesis, to which artificial teeth will be added as natural teeth are lost one after another. So say you're having a series of extraction done over a set of months, right? Then you don't want to lose, say you did extraction of a molar today, and then 7 months later you're doing the rest of the teeth as well. In that time, we know you're going to lose teeth, but until then you want to preserve the space, not let other teeth close the space. Residual ridge resorption needs to be protected, right? Therefore, all of that is done after extraction tissue changes have occurred. So we don't wait, unlike, for example, with interim, you take the tooth out, you put the denture in, like immediate dentures, right? But with transitional, you wait till the healing is done right after post-extraction, then you put the denture on, then extract another tooth, wait, add another tooth, and move on. Treatment denture is purpose of treating or conditioning the soft tissue, treating or conditioning soft tissues that have been abused by ill-fitting dentures. Now that happens a lot. Whenever there's ill-fitting dentures, there are two types of issues that can actually take place: mechanical and biochemical. Now this is not a classification from a textbook, this is my own. Mechanical means the actual ridge is being lost, residual ridge resorption. And biochemical, I want to put it as candidiasis. Candidiasis is a huge issue under ill-fitting dentures that people just wear for a long term. Or food impaction, that's another biochemical reaction that kind of leads to caries. Or whenever there's clasps that are around, so if this is a tooth and the clasp is surrounding here, imagine if this is so tight around here that food gets entrapped here and oral hygiene instructions are not being followed, it leads to caries in natural teeth, and all of a sudden this tooth is a bad tooth to support the denture. And now we have to create the whole denture design again, right? So that's where treatment dentures kick in. So generally, say, used after surgery to protect a surgical site, or repositioning of a soft tissue in a flap scenario. So here are some diagrams that explain our purposes. So imagine this area, whatever this white area is used to support the soft tissue treatment that's been conducted, or whenever there's been so much damage that soft tissue recontouring needs to take place, where this denture is currently used. Now, of course, you can tell that these two teeth, this tooth and this tooth, which is these two teeth, this tooth and this tooth, are restoring the aesthetic functions of it, as well as partial functions. I don't want to claim to have this entire thing functionally ready to go. It's just a treatment denture, right? So, definitions and terminologies. Moving on to tooth-supported distal extension and an appliance. Okay, so tooth-supported RPD. Tooth-supported is where a part or the whole dental prosthesis that depends entirely on natural teeth support, which means there's a tooth here, edentulous spot, and there's a couple of teeth here. This is a tooth-supported denture. The acrylic denture base on or a cast metal frame, whatever goes in between here with the clasps surrounding it, this is supported because these teeth have a very strong periodontal support to make this area work. That's tooth-supported denture. Distal extension. This we can say tooth and tissue supported, because distal extension, meaning there's teeth here, which is the anterior component, and edentulous space follows into molars area, and then of course the ramus if this is a mandibular case. Here there are no teeth. So part of the denture is supported by these strong teeth, and part of the denture is supported by this soft tissue that is distal to the edentulous spot, the distal to the teeth. All of this area is soft tissue. Therefore, tooth and tissue supported denture. A removable prosthesis supported and retained by, of course, natural teeth, but only at one end of the denture base segment, and in which a portion of the functional load is carried by the residual ridge, which is this section here. And of course, the appliance. It refers to a device or devices such as splints, orthodontic appliances, space maintainers, These are worn by patients during an active treatment. And of course, orthodontics will have a lot of these appliances that are removable as well. And often they are incorrectly used to term as a prosthesis. It's not really a prosthesis. It doesn't replace function and aesthetics. It's used in a treatment. Therefore, it's applied science, hence it's an appliance. And here's the example of an appliance on the left-hand side. So we got banded molars and of course a functional component coming through. That's an orthodontic appliance, whereas this is a prosthodontic appliance. And this is technically prosthesis, right? Appliance, prosthesis. Perfect. Okay, so let's take a look at some definitions and terminology of parts of a denture, right? So we're going to go parts of a cast partial denture. Okay, so abutments. Any tooth or portion of a tooth that serves to support, retain a prosthesis. Abutment is generally a tooth, right? It's a portion of a tooth or any tooth. It's just a natural tooth on which we've used these components to allow a retention of the denture. So fixed partial denture is cemented over abutments. Removable denture is clasped over abutments. So these are called as direct retainers. What does that mean? So just so that we're clear with the words here, this tooth, which is an abutment tooth, when used for, say, FPD, which is a fixed partial denture, we haven't covered that yet, that is cemented over. Therefore, it's fixed. But as soon as we use RPD, which is removable partial dentures or cast partial dentures, these are going to be a direct retainer component surrounding that one abutment tooth. Therefore, that retainer is a fixation device or any form of attachment that applies directly to an abutment tooth. A direct retainer is used for a fixation of prosthesis. Right? Fixation of prosthesis, which is removable, remember. And that's why it's a component of the RPD. Then comes the cast. It's a basic, it's an accurate reproduction, right? Positive reproduction of a mandibular and a maxillary dental arch, whereas a model is a reproduction of the arches given the purpose of demonstration and display. There is discrepancy in accuracy when it comes to model, and this has to do with material use. For example, this just could be plaster, whereas a cast will be actual dental stone type 4, right? And then, of course, dental stone type 4 is strong. Okay, so let's take a look at the parts of a cast partial denture. Now, of course, this is a very interesting but a very deep slide. So first of all, a cast partial denture. Let's take a look at what that means. Cast partial denture. Cast means there's got to be metal components involved in it, right? So we have this gray area that is completely covered in metal. And then there's the pink area, which is now the replacement of an acrylic denture base, right? Specifically, say, replacing these teeth here. Okay, so let's take a look at one by one. A is the major connector, right? So we have a major connector. Major connectors are a component of the cast partial denture that connects the left side with the right side. Minor connectors with other components on the other side of the minor connector. There's so many connections, right? And it gives a really strong rigidity and support to the whole denture base, the other components, and so on. Therefore, that is the major connector. Now, the other components that are involved in this section are minor connectors. So another minor connector, which is B here, right? It's a little appendage, like an arm, that comes out of the major connector and touches other smaller components of the cast partial denture. So the function of a minor connector is to extend off of the major connector and go up to the components involved in retention. Okay, so that would be minor connector. Then comes rests. Now rests are very important, but for us to understand rests, so for example the C here, right? The C here is so important to understand because there's rest and there's rest seats. So let me explain that to you guys. I'm going to draw the tooth in two sections, okay? We've got a occlusal view, and then we have a buccolingual view. So I'm looking at the buccal surface right now, okay? So now imagine if I have a component called rest, right? Rest is basically something that just sits here. If I have the rest that is currently sitting right there, and I have a opposing tooth come into play, there will be, before the occlusion can occur here and here, there will be a occlusal interference. It would create an occlusal interference, right? There would be something in between the occlusal region. Therefore, what we need to do is have a preparation. And this term is very, very important, guys, because in the construction of a RPD, there is a whole process called as mouth preparation. And without this step and the steps preceding, this cannot happen, guys. Okay? So, mouth preparation. One of the steps of the mouth preparation is known as a rest seat creation, right? Rest seat creation. What is the rest seat? It's a actual recess created in the natural tooth surface, a recess. We actually use burrs to take that structure away so that the rest components, the labeled C here, can come in and sit within this section, sit within the rest seat, right? And therefore, whenever there is a tooth opposing coming in, there is no occlusal interferences. Therefore, there are two things that are involved in the rest family. There is a rest itself, then there is a rest seat. Okay, so the rest is associated with the cast partial denture or RPD, and the rest seat has to do with the tooth. Okay, so let's clarify that confusion right then and there, guys. Rest seat is tooth, and rest itself, the component, is on the cast partial dentures, and that makes us the rest family. Then comes a retentive component, right? Now, retentive component is just like that. There's principles behind it. So what is a retentive component? In this case, it's the D. It's the D section over here. Right? It surrounds the tooth. So it comes across the minor connector and into the front of the tooth, or the buccal surface of the tooth in this case scenario. Right? So what does that look like? Why is there a retentive component like that, and what does it retain? How does it retain? Right? Let's take a look. So same thing, I'm going to draw two surfaces of the teeth. So we're going to have a buccal surface. So I'm looking at the tooth buccally. And then, of course, I'm going to look at it mesiodistally this time. Mesiodistally. Right? So this is lingual side, buccal side, and of course this is the buccal view of it. That makes this the mesial, the distal. Okay? Now, here's the thing. We have a rest coming in on the rest seat, right? Rest coming in. That's, I'm representing this tooth here. Rest seat's coming in, and it comes off of a component that we haven't discussed yet. That's known as the proximal plate. Okay, it's a plate, right? This is a plate. Where is it located? On a proximal surface, therefore proximal plate. Then, of course, the minor connector comes in, say, connecting this area to the major connector that kind of flows out, right? Major connector. So, proximal plate. Now, from the proximal plate, an arm comes out onto the buccal surface. Right? An arm comes out onto the buccal surface. This arm's function is to retain the whole denture. Imagine if this arm didn't exist and I tried to pull this denture out of the tooth. How easy would it be? It just comes right out. But this section, its job is to prevent that withdrawal. right? Well, how does it prevent it? It can still come off, right? Well, actually, there's a concept called as height of contour. See where I've drawn the yellow circle, guys? That is the widest or the most bulgiest point of the buccal surface of the tooth, right? Bulgiest point, this area. This is known as the height of contour. Contour is just the surrounding tooth structure, the shape of the tooth, right? The height of it. Now, what this arm must do, the purple arm on the top diagram right here, is that it must come off the proximally placed plate on this section and come under the height of contour and attach itself below in a section known as an undercut. Okay, so this is an undercut. So what that does is whenever, if the rest is sitting here, proximal plate is here, the arm comes off and attaches itself down there, right? It crosses the height of contour, goes in the undercut region. Now imagine trying to pull this denture base out. This arm will lodge itself in this section and will not let the denture come out. Therefore, it's a retentive component. In other words, retentive components must always engage undercuts below the height of contour. So that statement is very underrated. I mean, we really need to focus on that statement again. A retentive component is a clasp that crosses the height of contour and attaches itself below the height of contour into an undercut, where if the forces are applied to remove the denture, it stops itself. Fair enough? Perfect. So that is a retentive component. Now, every time there is a retentive component, there will be a reciprocal component. And the reciprocal component is this section right here, which is E, right? Which is on the other side of the tooth. So now imagine, what we've done is we've created a retentive force, right? A retentive force where if the denture base is trying to be removed up front, what that does to us is it creates a force that turns the denture around, right? If the retentive component is trying to remove itself, so if I erase this and I draw you a new one, what that would look like is as follows. I have a tooth with a height of contour, lingually not so much, rest seat, proximal plate, right? And then I have a height of contour here, and I have a retentive component coming out. Right, let me draw that in the red here. Coming out like that, okay? It engages itself in the undercut down here. What that does is whenever we try and remove this entire structure around, it rotates out of its proportion. Therefore, we need something that is in here. Pay attention on this side, above the height of contour on the opposite side to prevent this rotation. Fair enough? Where will that go? So height of contour, right here. Right? This section will not let this rotation occur. It'll stop that turn, and it will make sure that it doesn't go below. It doesn't rotate itself. It will not rotate. That's a terrible drawing, by the way. So what it does, it doesn't rotate inwards. It prevents it because there is also a height of contour here that will not let the arm come inside into the undercut on the lingual side. Therefore, the reciprocal arm's job is to prevent rotational forces, also known as, say, torques, or the dislodgement of the cast partial denture into the other side of the rotational forces, and it prevents that rotation caused by the removing forces of the retentive arm, right? And of course, this is very exaggerated. It's very, very minor forces. I'm talking fractions of millimeters. Okay, so that reciprocal component. And of course, the pink area that we were looking at earlier, this area, that, our friends, is a denture base. A denture base is basically something that attaches to the major connector, and then the grid and the whole mesh work that we were talking about in the earlier slides. So if you ever were to look inside, like if you were to see through this acrylic area, the pink denture base area, there's going to be a grid of metal, right? Same metal, cobalt chrome. Or sometimes there's a mesh of metal. And then the pink stuff, the acrylic, kind of interwoven within this section here to kind of get a sturdy scaffolding made, and the teeth are then attached to the denture base. So that's what it would look like. And therefore, the G is called the denture base, or the F is called the denture base, and the G is now called the replacement teeth, which are just very simple, right? Retentive or replacement teeth are very, very common. And they're made out of acrylic. Wow, that's black. Sorry. Sorry, my pen's not supporting today, guys. And now H. H is called an indirect retainer. Now, what's H? It's right here. Wow, so this is a whole new component. Now, let me explain what an indirect retainer really is, okay? This is very exciting because our job, whenever we do a RPD design, it's to make sure it stays in the mouth. Even though it's removable, we don't want to have to chew something sticky and have the entire denture come right out, right? That's where the retentive clasps come in. Now, whenever the retentive clasps are in action, imagine the force that would be placed on the height of contour area, right? That is reciprocated. So many functions overlap with one another, but imagine this now. In this section, in this diagram, we noticed there is a retentive component here, right? Rest, the indirect or the clasp retainers, right? All of that is there. This section is known as the clasp assembly. Clasp assembly has rest, it has reciprocal arm, and a retentive arm. Okay, all of that very easily understood so far. Now, this area will directly retain the denture onto the abutment tooth. Okay, perfect, great. But imagine this, on this side, there's another clasp assembly, and now there's a retentive component, direct retention component, that is seated opposite side of the arch at an angle, right? What that means is this area has no teeth, this area has a lot of teeth, this area is a direct retainer, this area is a direct retainer. Okay, no problem. Now, and I'm taking it very slow, guys, so bear with me here, but it's very important to understand this concept. What that does is whenever we chew food, there's two lines that are formed, okay, invisible lines. One line goes from a rest to a rest. This is called as a support line. This is called as a support line. Why? Because rests support. Okay, what's a support? Whenever we chew food, and if this is the tooth, right? If this is the tooth and we chew food and press against the tooth, there's tissues underneath here. Whichever component prevents this movement so it doesn't hurt the bone underneath here, it protects the bone and the tissues underneath here. Whatever component prevents the further movement towards the tissue, right? I'm going to write this down, guys. You guys also write this down. Towards the tissue, it prevents that movement. That is called a supporting component, okay? So we know that the rest is seated on top of the tooth right here. And whenever there's forces applied here, it prevents it because it's seated on the tooth. It prevents the forces going towards the tooth surface, the tooth structure, right? Like it's right here, PDL. It prevents the forces going towards PDL. Okay, perfect. That, my friend, is called a support component. Okay, so rest is a support component. Therefore, a line that goes through The supporting regions known as rests is known as a supporting fulcrum line. So the first line is called a supportive fulcrum line. Okay. Second component is the retentive components, both areas. And a line that kind of goes through the retentive component is known as a retentive fulcrum line. Fair enough? Okay. What happens is, imagine I try and push this denture base out. I want to push it out. What would happen? It would rotate among these fulcrum lines, right? It would rotate among these fulcrum lines. It would try and lift itself in that direction, right? In that scenario, when the denture base rotates along these lines, there must be something at the opposite end here that prevents that rotation. So if I zoom into this tooth right here, the H section right here, what would that look like? It's a K9, so it would look like this, and there is a rest created. It's a rest. It's essentially just a rest, right? That is seated into the cingulum area on a rest seat preparation, right? Whenever a rotational force kind of hits here, so here, it prevents the movement of the denture. So essentially, this force is prevented by this particular rest. And therefore, that rest is known as indirect retainer, guys. Okay? Indirect retainer. It indirectly retains this force. Indirectly retains this force. Okay? So, indirect retainers, two things to remember. It indirectly retains the denture when a force is applied on these fulcrum lines, and it must be located furthest away from the fulcrum lines at 90-degree angles. Okay? So indirect retainer must be located furthest away from the fulcrum lines at furthest away, okay, and second at 90 degrees perpendicular from the fulcrum lines. And that is the whole composition of an RPD. So now guys, the next few slides will now be very easy to understand since we kind of looked at the parts and how they function. So what is retention, guys? What is retention? It is the inherent denture quality that resists vertical forces away from the ridge, which means removable forces. So forces that remove teeth. Now what removes it? In a maxillary case, it's gravity. In a mandibular case, it's sticky food, right? Things like that. Vertical forces, that's what we need to know. Forces of dislodgement, such as gravity, sticky food, or jaw opening movements where muscles try and remove that denture. Then there's support. Support is the resistance of the forces, great, aimed towards the ridge, downward forces, into the ridge, the tissue. These are masticatory forces that might be so high that it may hurt the tissue, and of course it's supported by rest. Rest, right? Okay, then comes stability. Stability is the quality of the prosthesis that remains firm and stable, right, and consistent in its function, while at rest, right? So it's the resistance of horizontal forces of displacement and functional and rotational stresses. Now I want to point out to us here the rotational forces, functional forces. Remember that the reciprocal arm, when the retentive arm was activated, it rotated the denture base. And of course, we're exaggerating, it's very micro, but it hurts the patient. So functioning at the time of function, retentive arms move up, engage into the height of contour, and it creates rotation. During those stresses, a horizontal component must be preventing that rotation, and that is reciprocal arm. So far what we've gotten, guys, is retention is done by retentive arm, right? Support is done by rest seats and rest component, and stability is done by reciprocal arm. And now we're on to cross-arch stability. It's the resistance against dislodgement or rotational forces established by a specific design of the RPD. Okay, fair enough. Very simple. One side of the RPD uses natural teeth, and the contralateral side uses edentulous space. Okay, what does that mean? Well, if you look at the diagram that we had in the previous slide, one side had edentulous spaces in the back. The other side had tooth components, the whole clasp assembly. They both provide cross-arch stability through major connector. It connects one through the other side, one left side to the right side. They're different components of the RPD, but the major connector connects them together. Okay, perfect. Okay, so indications and contraindications. Normally speaking, FPDs are the choice of prosthesis for partial edentulous cases. However, some factors favor RPD. Now, which factors? We'll take a look. With implants in the equation, RPDs are no longer the first line of treatment. Implants are great. They are very costly, but RPDs are cost efficient. So let's take a look at some extraoral factors and intraoral factors. Okay, extraorals are ages, gender, general health of the patient. It's a representation of the oral health as well. Occupation, depending on what they do, some people really need aesthetic demands, and we don't need metal components showing. Socioeconomic status, of course, the cost of the appliance, the RPD itself versus a implant retained denture. Patient's autonomy, patient's compliance. These are patient's choices of both oral hygiene when it comes to compliance and autonomy for what they really want to have on their own, regardless of other factors. And of course, time factor. Then comes intraoral factors. Intraoral factors include distal extension cases. Distal extension cases, RPDs tend to serve really good, but I would remember that implants have periodontal support greater than a RPD, so it kind of helps better. Edentulous spans, if it's a very long span, of course, then that's a lot of implants, right? That's when we want a RPD. A reduced periodontal support, whenever the ridge is already lost, implants may not be the best idea. We need some periodontal support for implants to sit in, right? That's where RPD comes in. But again, if it's a very thin bone, then RPD might not last well. Cross-arch stabilization, that's also the component of the RPD. Then ridge resorption, we just mentioned the thinness of the ridges. Aesthetic, yep, that's a demand. And urgency of replacement. If you need it tomorrow morning, implants are probably not the best choice, as well as FPDs. RPDs become better choices. And intraoral defects, if there are so many intraoral defects, such as say ridge collapse, right? Or vertical dimension is so low, then creating a denture base with metal, acrylic base, as well as tooth on it might be difficult. Vertical dimensions, that's the VDO, VDR that we had talked about, and of course the poor prognosis for a CD. Whenever the complete denture is not good at prognosis, then we need to consider other modalities such as a FPD or a implant. So indications. Now let's expand onto them, right? The age. Whenever the age is, say, 17 years and below, FPDs are not indicated because FPDs require tooth preparation. So imagine if I need to cement a denture onto this tooth, and of course this is a pulp cavity, right? The pulp chamber and the pulp. If I need to prepare this tooth surface, right, and I'm going to cement a abutment on it, create an abutment and cement a direct retainer on the abutment for an FPD. And of course, I don't want to get into FPD yet because that's a new lecture series, but essentially what we need to do is we need to create a crown. So we would remove tooth structure and create a crown. But imagine how close this is to the pulp, because the age is so young that the pulp horns are very large. Therefore, elderly patients are much better with FPD. But again, if they have health issues being paid for by self, FPDs might be a little bit more expensive for them. Now, that's just very generic, right? We can't really label everybody of the same category, but just generally speaking. In genders, females desire more aesthetics. Okay, so females really like aesthetics. So FPD might be a better choice, but there's no analysis with this. It just depends person to person. Some of these factors are also outdated, and the world changes on a daily basis. General health. Poor oral health. If you take a look at poor oral health, we cannot have an FPD where there's poor oral health, right? We need interim RPD before they get into definitive, say, even if it's FPD, even if it's FPD, before they get into that, they need to have a better oral health. Therefore, until then, interim RPD is much better. Occupation and economic consideration, of course, that's a really, really big win, where RPDs are more affordable in nature than FPDs. And contact sports, such as rugby players, they're better treated with RPDs, because FPDs, if they're placed and there's a lot of trauma, that's going to be a problem. With the abutment teeth, like this tooth would be completely destroyed if a rugby player got damage to it. Then comes patient desires and attitude. That's autonomy, and of course their compliance, their oral health compliance. Are they able to keep it clean? Dental anxiety for tooth preparation. If people have issues with, say, the noise of the drill, FPD might be a secondary option for that type of a patient. Time factor. Time factor is huge. Interim partial removable dentures are indicated with a fast treatment. Right? And then, of course, other cases which are more important, distal extension regions. Then there's longidentulous spans. So that's kind of hand in hand if you think about it. Distal extension cases are when we have no posterior abutments, right? It's the tooth and tissue supported scenario where FPDs are less sustainable, right? A cantilever FPD must be created. Imagine cantilever, what that really means is if there's an edentulous span here and there's a tooth here, right? What we're trying to create in this scenario is this section at the front retains the whole denture, and this is a flipping side, right? A flipping side, right? That kind of goes back and forth because the center of gravity or the rotation is all the way here, and it goes back and forth. So that's a cantilever. So that is a issue with FPD, or an implant that may be placed to hold the abutment. That's better for the whole scenario. So if I put an implant right here, all of a sudden this edentulous span becomes shorter, supported by teeth on both sides, and this movement is prevented. Okay, so that's the other side of the coin for distal extension. However, in cases where there's previous factors that are an issue, then RPD is better for distal extension. So it's case-based. Long edentulous span, violation of Ante's law. Now, Ante's law is generally for FPDs. It's reserved. What that, in short, what the Ante's law is suggesting is that if I have 4 teeth missing, right? I have 4 teeth missing here, and I have 2 teeth that are anterior to it. The root surface area of these 2 teeth have to be compatible, have to be strong enough, or has to be high enough. Surface area of the root has to be high enough to withstand the forces that will now be placed as equal to as 4 teeth, right? So Ante's law says that the root surface area, so root surface area of the abutment teeth must be higher than the missing teeth. Now, whenever there's a violation of this section, we can't place FPD, right? If we need to have an FPD that is basically, say, imagine it's being fabricated here as a direct retention component of the abutment teeth. That's only 2 teeth, and I'm replacing 4 teeth. FPD will fail. It will break off here, right? Therefore, an RPD is now created. RPD is better. So as soon as Ante's law is kicked in, it's RPD. RPD is better. Now, okay, of course, that's just very, very specific to one example. These are very clinically designed, like they're very deep and intricate. So this is just superficial, guys. It's a general RPD lecture. Then comes our next point in line here, where more than 3 teeth are lost, they're replaced by RPD. This is just a general rule of thumb we follow in practice. Less than 3 FPD, more than equal to 3 RPD. Missing teeth. Okay? Perfect. Moving on to the next point. Reduce periodontal support for remaining teeth. Whenever there's reduced periodontal support, RPD, right? It allows for support to be distributed among many teeth on the ridge itself. Unlike FPD, FPD needs to transfer that force on the prepared abutment teeth. So that's very hard, guys. Then comes cross-arch stabilization. Cross-arch stabilization is best delivered by RPD. So FPD, for example, provides lateral stabilization, one side, a proper stabilization of that area, the bridge area, we call it, right? Where RPD provides everything, lateral, anterior, posterior stabilization with the major connector and the minor connectors coming up. It's so perfect. So in that sense, if we need cross-arch stabilization, it's an indication for RPD. Excessive residual ridge resorption. Now, excessive residual ridge resorption means that the denture base that we create as flanges, it kind of creates a support for the new teeth, even though the residual ridge is so small after extractions. The FPD may not replace the lost tissue entirely, right? And of course, the FPD will transmit the forces into the residual ridge itself. So what we need is a denture base mimicking a ridge that has been lost. Therefore, RPD is better. Then comes aesthetics. Aesthetics, FPDs are kind of okay, right? They may not appear natural, but RPD, because they're acrylic teeth, they're better. FPDs have to be, say, zirconia or PFM, porcelain fused to metal, all ceramic. These don't look like natural teeth. Now they do, though. Nowadays, there's so much characterization that goes into the fabrication of these crowns that they do look like natural teeth. But overall speaking, acrylic teeth better represent aesthetics in an RPD. Anterior teeth replacements can be done with implants or RPDs. Okay, there's more. We have immediate replacement of post-extraction. Immediate replacement means so I took extraction treatment today. Teeth are out, sockets are healing, and I have to cover it. Remember, this is the interim denture for post-extraction sites. It stimulates the lost portions and natural contours. It protects them, and this is the immediate denture. We'll make an immediate denture lecture in the future. It acts as a splint, right? It's better for healing of the ridge that the tooth has come out of. After healing is complete, a definitive prosthesis is placed, guys. Okay, intraoral defects. Of course, if there's clefts, they're closed using the RPD, right? If there's a palatal cleft, we just use the denture base and we close that cleft. Obturation of intraoral defects, same thing. It's the added benefit to the RPD. And then abutments with questionable prognosis. So abutments are the teeth that are used to create support. Therefore, a transitional denture for deteriorating abutment is headed for extraction. So transitional was, I took a tooth out, I made a denture. You took that tooth out, I remade the denture. I added an extra tooth to the new extraction site. Transitional dentures are better in that sense. Transitional dentures are a RPD. Alteration of vertical dimension. If the vertical dimension needs changes, and it's a gradual change, say you need 2 or 3 increments, then FPD cannot provide that gradual growth. FPD is permanent, it's done. But RPD, transitional dentures, they can. Poor prognosis for a CD. Whenever you can't make a CD. For example, when there's a retrognathic jaw relation. Retrognathic jaw is A class 2 mandible is pushed back. That's better treated with RPD than CDs. Right? This is achievable because there's balanced occlusion and lingualized group occlusion. Right? Imagine whenever we're trying to achieve that with a CD, well, that's going to be hard. There's a whole lecture on it, right? We looked at it in the previous videos. So please do look at the occlusion lecture for that detail. Okay, so generally contraindications, there's not many, right? There's not a lot of contraindications. However, whenever feasible, FPD is chosen. It's just stronger. But for FPD to be chosen, Ante's law must be met, guys. Then comes circumstances where RPDs may be avoided. When do we avoid RPDs? That's completely new to us, guys, right? Patients who lack dexterity to insert prosthesis. So, manual motor dexterity loss. Say Parkinson's patients, for example. Patients who lack oral health awareness because, remember, clasp assembly, rest seat, rest preparation, the proximal plate, the denture base, major connect, so many parts to one RPD that we need to keep everything clean. They need to remove the denture at night, brush the denture, keep it clean. All of that is not there, then RPD cannot be given because it will fail. Epileptic patients that are in danger of swallowing a denture or its part during an attack, right? And Ante's law we'll discuss more in a FPD lecture, guys. Okay, so the infamous Kennedy's classification, guys. Okay, so let's take a look at 4 classifications, type 1 to 4. Very, very simple. There is a bilateral, right? I'm going to change the color here, it's better. Bilateral edentulous area on 2 sides, left and right, located posterior to remaining natural teeth. Okay, so we're going to put some mnemonics down to help us understand. Okay, guys? Bilateral edentulous area located posterior to natural teeth. So that is bipo. Bilateral and posterior. Okay, so bipo. Keep that in mind, guys. Class 2 is unilateral edentulous area located posterior to remaining natural teeth. That is unilateral, so only on one, either left or either right side, still posterior. Unipo. So bipo, unipo. Okay. Class 3 is unilateral edentulous area with natural teeth both anterior to it and posterior to it. Okay. So a unilateral area that is not posterior, it's actually anterior to remaining teeth bounded by other sets of teeth that are further anterior. So just a unilateral area, and I'm going to go uni-ante. Okay, unilateral anterior. And then class 4 is bilateral edentulous area located anterior to remaining teeth. This is basically when incisors are missing, all the posterior teeth are present, but it crosses the midline, therefore it becomes bilateral and it's an anterior, so we're going to go bi-ante. So an easy way for me to remember when I was studying for it, it was bipo, unipo, uni-ante, bi-ante, right? So bipo, unipo, that's class 1, class 2, and uni-ante, bi-ante, these are class 3 and 4. So what's the difference between these two? Think of it this way, guys. The posterior edentulous spots are bounded by teeth only on one side, right? There are teeth that are located just a little bit anterior to them. Therefore, these are tooth, of course, on one side and tissue supported. So both of these are tooth and tissue supported. Whereas for class 3 and 4, the uni-ante, bi-ante, there's teeth on both sides of the edentulous spot. Therefore, these are just tooth supported. Both of these. So remember that as well for classification, right? This is going to be 1 and 2, and this is going to be 3 and 4. Okay. Okay, so then what would this be? Over here we have bilaterally edentulous spots that have teeth anterior to them. So bilateral posterior. Right? Bilateral posterior. Bipo. This is class 1. It is tooth and tissue supported. Okay. Now next one. We have a unilateral, only one edentulous space where teeth are anterior to it. There is no teeth posterior to it. and that is unilateral posterior, unipo, which is class 2, and it is tooth supported and tissue supported. Fair enough? This is class 3 because it's unilateral. Both sides are tooth supported. There's tooth posterior to it and tooth anterior to it. So that is uni Ante. Ante is the anterior edentulous spot from a tooth that is posteriorly remaining. This is class 3. And what remains is, of course, class 4, where there is a bilateral, because there's a midline here, so bilateral, edentulous spot that have teeth on either side, both sides, right? So that is bi Ante. That is class 4. Okay, so Applegate rules. Before we do begin, I just want to correct a little bit of information here so I don't mislead you. I'm going to rewrite it, the rule number 3 when we get to it, okay? So, rule number 1. Applegate rules must be followed, by the way. The first one is that classification will follow extraction. First extraction, then we do classification. Simple. Rule number 2 is if the third molars are missing, okay, and then we're not using the third molars in the denture base to replace them, then we don't count them, okay? The third rule that I'm just changing because I miswrote here, rule number 3 is if the third molars are present. So if the third molars are present and are being used as abutments where the clasps will go, only then you count them in the Kennedy's classification. But imagine if they are there, if there's third molars there and they're not being used, they will be extracted in the future, then extraction will precede the classification and all of a sudden the third molars are no longer counted. Okay? Hopefully that helps, guys. Rule number 4 is whenever there's a second molar in the same scenario, right? Rule number 4 is when second molar is missing, it's not being replaced, don't count it. So basically the posterior most edentulous spot will determine the classification, and that's rule number 5. Posterior edentulous determines the classification. So if there are like multiple missing teeth in all different areas of the arch, whenever you want to do class 1, class 2, class 3, class 4, we must consider the posterior most edentulous spot to classify it. So we'll do an example in the next few slides so that we understand. Okay, then we have rule number 6. Other edentulous spots, so say we did the posterior most on this side here, then there's of course some other spots that are edentulous, right? Other spots are now called as modifications and will be numbered. Each edentulous spot will be given 1 number. So only number of modification spots are considered, not the actual spans of missing teeth. And this rule I'll be able to explain when we do a diagram in the following slides. Rule number 8 is a class 4. Remember, class 4 was the bi-Ante, anterior. They do not have a modification because they themselves are the only edentulous spot present. Because if they have class 4, anterior missing spots, right, and they have a posterior missing spot, that posterior missing spot becomes the classification. It is no longer class 4. Therefore, class 4s have no modifications. Okay, so let's take a look at the diagram to clarify some confusion. We mentioned that if third molars are used, only then they're counted. So in this case, third molars are used. Okay, there is an edentulous spot here and edentulous spot here. Okay, the furthest posterior edentulous spot, which means here there's no teeth, therefore this becomes the most posterior spot. That becomes the classification, and an anterior edentulous spot, 1 tooth ahead, even if it's 1 tooth ahead, this becomes a modification. So what would this be? So for now, let's black this region out, right? We don't need it. This does not count because we're trying to do posterior most spot, okay? So posterior most spot, this is going to be a unilateral posterior, unipo, which is class 2. Great. Okay, class 2. Now, how many other spots, not how many teeth, how many other spots are missing? Only one. Everywhere else there's teeth. So that would be a mod 1. Fair enough? So this cast right here is class 2 mod 1. So let's use that logic here. Same applies here. Posterior most, which is unipo, which is class 1. There's only one other missing spot, no other missing spots, and that is modification 1. Sorry, it's class 2, modification 1. Apologies. Class 2, modification 1. Okay, let's move on to the other one here. The posterior most edentulous spot missing. This is going to be class 2, unipo, right? Class 2, unipo. Modifications, there's one missing spot, two missing spots. That's mod 2. Class 2, mod 2. This spot right here, what is the posterior most missing spot right here? Okay, what is that? It is bounded by a posterior tooth and an anterior tooth, which means this is a unilateral anterior site. So uni-ante, which is class 3. What other spots are missing here? One more spot, one more spot. That is mod 2. Now, why is it that it's just this spot that counts? Well, remember the rule in Applegate's that the posterior most edentulous spot makes the classification, right? It makes the classification. Fair enough? So let's do a pop quiz, guys. Let me see if you can pause yourselves right here and then create your own answer keys, and then we'll go through with what they actually are. Okay? Here we go. Pause and play. This is known as a class 4, right? There's just one. There's no other. It cannot have any other missing teeth. So class 4 crosses the midline. Okay. This is a unipo, which is class 2, with two different modifications. So class 2 mod 2. Okay. This is bilateral edentulous spots in the posterior. So bipo, which is class 1, with one more missing site, which is mod 1. This is uni-ante, which is class 3, with 1, 2, 3 modifications, so mod 3. This is uni-ante with one modification, right? Unilateral anterior. You could pick either one. It could be uni-ante because they're both replicas, and this rarely happens, by the way, with mod 1. So class 3, mod 1. This is missing area, so this is bipo, which is class 1, and two modifications, mod 2. And of course, this is a class 4. Simple. This is a one entire side missing, and it's not crossing the midline. Therefore, this is going to be a unipo. Unipo is class 2, but no modifications. So just write class 2. Okay. Now this one, guys, what do you think this is? Most posterior most. This is uni-ante, which is class 3. And then how many mods are there? Let's count. 1, 2, 3, 4, 5. And that's mod 5. Okay. Hopefully that helps you guys. Now, lastly, finishing up today's presentation, we're going to be discussing the steps in the RPD fabrication. And of course, we'll step into each of them. These are each chapters, guys, right? Like before we even begin into it, for example, if I were to explain to you survey, it would take me 2 hours to explain survey, guys. It's that interesting and that deep. Also, mouth preparation. We kind of touched upon it for a rest seat preparation, but oh my God, this is a whole topic in itself, right? Trying process, oh, so much. Jaw relation, so much. So let's take a look at just the steps today. Let's build on it little by little, right? First of all, we do examination and diagnosis. Diagnosis is now a basis. Right after extraction is done and we've done examination, we establish a Kennedy's classification. We then made a diagnostic cast. On the diagnostic cast, we prepared surfaces. We prepared things like this rest seat preparation right here. We did, where the clasps will go. We kind of designed where the major connector will go and so on and forth. We designed all of that. That's preparation of the mouth onto the actual diagnostic cast. And then we prepare the actual teeth replicating the diagnostic cast. Once the teeth are prepared, and for example, when rest seats are made right here, rest seats are made. Oh, and all that is made, that's when we do a secondary impression. And then the final dental stone master cast is prepared. But now we have to check. We have to check. We have to survey. We have to make the design precise, maybe change a little bit of things. We have to give relief into certain areas that are kind of sticking out. Some of them are called as undercuts, right? Undercuts are areas where once the metal component, for example, this area, sticks in, it cannot come out. So we have to give relief. We have to block that out. And then, of course, beading can be done along the line of the major connector where acrylic denture area where the denture will flow, kind of limit the flow. It'll give space underneath the metal component and so on and forth, right? Over here, imagine this meshwork that's there, right? This meshwork right here. Inside, if you can see, that needs to be beaded and boxed as a whole step. Now, again, we're not stepping into the boxing and the beading and so on. This is just steps. Then we duplicate the master cast that has now been surveyed and designed, and now a refractory cast investment. This is refractory because it's given under a lot of temperature, right? And that wax is now going away, right? So we give a relief wax, block out wax. Design, beading, and boxing, all of that wax is blowing away, and casting is invested within that design. And that whole process is known as waxing and casting. Okay, waxing and casting. Once the casting is done, we do try-ins. We try it in the patient's mouth, and then we record jaw relations. We make sure that the vertical dimension of occlusion is really good. Vertical dimension at rest is properly 2 to 4 millimeters away, so on and forth, right? The jaw relations and dimensions have to be taken into account. After that, we have actual child denture with teeth arrangement onto the wax component, onto the acrylic metal framework right here that is seated on the tooth. So if I draw it right here, this area, teeth arrangements are done. And lastly, the denture insertion appointment is established. And of course, we always maintain and recall at different intervals. Very interesting process. We will take a look at it later as well. So, as a recap, guys, I would love everyone to write this down on their own as well, where removable partial dentures have 3 types of components, 3 large components. What are they? Connectors, retainers, and functional units. So let's get over with the functional units, so that's out of the way. What's functioning? Denture base. They act as the ridge itself. Artificial teeth, they act as the mastication function, so functional units are out of the way. Perfect. Retainers. What retains? There's direct retainer, indirect retainer. Indirect retainer was that fulcrum line, right, that we were looking at in the previous slides. Indirect retainer. Direct retainers will have retentive clasp. We'll have rest on the rest seat on the tooth, and reciprocal clasp. This we called as clasp assembly. And then, of course, lastly, we're looking at the connectors. Connectors are major and minor connector. Major connector will connect left side to the right side, provide cross-arch stabilization, and minor connector is like a arm that comes off of the major connector to attach to the teeth with its clasp assembly. Perfect. So that's the classification of composition of RPD, guys. So now I'd like you guys to pause here, and without the help of this component, I would really request you guys to label the diagram yourselves. Okay, so I hope this really helps, guys. And these are the resources we use to introduce you to the RPD section. So McCracken is a well-known textbook used for all American and Canadian exams. And of course, I use Rangarajan because I enjoy their diagrams. They're very well explained in very simple terms as well. Of course, to get access to these textbooks, the links are in the description box below. It's just you go to our website, you register, and you have access to this plus 35 other textbooks, guys. Okay? So please stay tuned, and we will follow through with more RPD lectures, CD lectures, FPD lectures. Just like our pharmacology, we are now tuning into prosthodontics, guys. So thank you so much. Please like, share, and subscribe, and please leave your comments. We'd love your feedback. If you have any questions, please check out our YouTube channel, Facebook, Instagram, our blogging on our Tooth Factory's website in the description box below. For any queries, please contact us on our email also in the description box below. Thank you very much. Have a good day.